Thank you, Allison. That's a great summary of a paper that I hope everybody does have a chance to read. And I'm going to stand up and do introductions, and I'm going to sit down and ask questions. But the panel here that has been assembled represents a little bit of Medicaid, a little bit of mental health, a little bit of federal, a little bit of state. It's a good panel for generating discussion off of some of the suggestions and implications and recommendations in Allison's paper. Dave Mancuso, who's been introduced by Allison in some ways, is a PhD health economist and senior research manager for the Washington, I'll just call it Medicaid Agency, Department of Social and Health Services, and he has his initials are DM, David Mancuso. He's the data man when it comes to the kinds of issues that we're talking about. So we've encouraged him to throw some data elements onto the table at some point. Joan, we've worked with over the years in the state of Pennsylvania, where she was the Deputy Secretary for the Office of Mental Health and Substance Abuse for over 7 years, it says here, and now currently is working for a major behavioral health organization player in western Pennsylvania, although it probably gets out of western Pennsylvania a little bit. And Dr. Clark is the director of the Center for Substance Abuse Treatment at SAMHSA, and he's got a lot of initials behind his name that I'm not going to attempt to explain. I'll leave that to you, Dr. Clark, but obviously he's been in this space, including the Veterans Affairs and at UCSF, and he's going to be a great resource in this discussion as well. So, and I'd also, even though Sarah Summers is not a relative of mine, I encouraged her, I implored her to stick around, she's right here, in case we get into explications of the regulations and the legislation and potentially the regulations, and she has a colleague with her who shall go unnamed unless he wishes to be named, who also has some expertise in these issues. So with that, my first question is for Dave, and Dave, it says that the paper makes the business case for treatment to the expanded population, but it doesn't address the politics of that policy change. Can you please comment? And I think that there have been comments made earlier by the judge and by others about data and advocacy and opportunities to use data. And I think, Dave, you might be in a good place to talk about that.
Thanks for that surprising question. Let me consult my notes here. And my view into the politics here is really as a spectator in some ways, because as a health economist, I'm not in the room when those conversations are really happening. And it certainly, and what I'm going to speak from largely as it relates to Allison's points as well, is the experience of significantly expanding chemical dependency treatment in Washington State beginning about 6 years ago, the politics of that expansion, what we thought we knew before that expansion and what we've learned since about the impact of CD treatment on at least Medicaid cost offsets, and the implications for, I'll probably say something at some point about the implications of the impact of CD treatment on disease progression, injuries, infectious disease, and impact on folks transitioning to disability-related coverage, and the profound budgetary implications of that phenomenon under healthcare reform. But so I want to start, though, and I also want to say I'm going to be speaking a lot from the experience of chemical dependency world. There's probably a similar story to be told from the perspective of treatment of serious mental illnesses. We were never really tasked to look at that issue as closely as we were tasked to look at chemical dependency treatment. And that in part reflects the visionary leadership of Ken Stark, who was at the time the head of the Division of Alcohol and Substance Abuse. And the politics here are that it took more than a decade to strategically develop, implement a communication strategy founded on data and analysis to make the case that the legislature could fund a major expansion to CD treatment for Medicaid clients at no cost, no net cost, funded through cost offsets. So as you can probably glean from that, the politics were pretty challenging, given that this is something that ultimately was funded through assumed savings, so in a sense done for free, although if you're on the other side of that cost offset in the Medicaid medical program, you might have a somewhat different view of whether it's something that's being done for free or not. So the politics were difficult, and they took quite a long time of strategic messaging with visionary leadership and with a strategic vision for using data and analysis in a multi-pronged approach, both within state government in terms of the kinds of fact sheets and policy briefs people like me put out, but also funding external university-affiliated research, getting information, getting articles published in the academic literature, which has a little bit more cachet than the policy briefs that I publish on our internal website. Not to say they're better, but they certainly have more cachet. And part of Ken's vision that was entirely correct from the messaging perspective and from the political perspective is that the way to focus that research was not on the impact of CD treatment on the patient, on the person who's addicted, but to look at the outcome areas where people will care more. And those include cost offsets in other people's budgets, Medicaid in particular, but also the criminal justice side. It includes looking at the public safety impacts and the public health impacts and the child safety impacts of untreated chemical dependency. And to do those kinds of analyses require large-scale data integration. And I think in retrospect, it may seem kind of odd, but although there have been other key supporters of data integration across behavioral health and medical and both within our department and with other agencies, there have been other strong advocates for data integration. One of the key early supporters and somebody who really, in a sense, had the entrepreneurial vision to put up the seed capital for that data integration effort was our CD treatment division director. So the tiny part of the agency was actually a predominant funder of the earliest data integration efforts within our department, focused on looking at the impact of behavioral health treatment and untreated behavioral health problems on Medicaid costs and other services. So I guess maybe just to say a little bit more about the politics. We were ultimately successful in getting several, an extra $30 million in the first two-year budget cycle for CD treatment, largely for Medicaid populations. We're an average-sized state, so that's a fairly large amount of money for us. We got another $40 million the next biennium, and about the same the next biennium. And that money has been relatively untouched, as I understand it, although I'm not a budgeteer, in our current funding crisis. Although funding for non-Medicaid populations, who will be a key part of the low-income expansion population, that funding has been reduced and is probably at increasing risk because our budget situation is worse now than it was a year ago or 2 years ago. Right, sorry, I lost my train of thought there. Right, oh, I'm sorry. So although we were successful in getting a major expansion, we were not successful in getting to parity on our own prior to healthcare reform. So we were still, and I guess this gets back to the politics and the sense to which these services for this population are viewed as, these are in a sense the undeserving poor, I suppose, to use probably a quaint old phrase. We didn't get to parity on our own. And even as we were budgeting for this expansion, we were still in a position where instead of developing that budget as we do for other health services through a forecast process that's driven by caseload changes and in some areas by per cap changes in utilization, we were in a position where we still had to guesstimate how many people we thought we could get into treatment with additional funding and enhanced engagement efforts. And that certainly has not been how we've funded health services, where we wouldn't try, for example, to guesstimate how many people need insulin to treat diabetes. And if we ran out of money in the last couple of months of the fiscal year, we would tell people, sorry, we're out of insulin. We underestimated. Now, with the kinds of cuts that are on the table now, that, like the entire pharmacy benefit being on the table as a potential budget cut, that disparity is less less humorous. So I'll pause there.
Okay. Great. Thank you very much, David. And Joan, from the behavioral health side in Pennsylvania, both at the state, from your state experience, but also from your current experience, what do you think about, this is a surprise question, right? Yeah. What do you think about the delivery system that's out there for the current population and with both behavioral, mental health and substance abuse? And what do you think about its capacity to serve the expansion population?
Well, first, I really want to make sure that I reference my background a bit so that you know that one of the lessons I have learned extensively is similar in Pennsylvania, where we have 67 counties that are all unique and different. We also have all the states as being very unique and different. And so my frame of reference is predominantly from Pennsylvania, and as I'm learning about other states, it's not only the behavioral health systems that are different, it is the politics that are different, it is the culture that is different, it is the expertise that is different, and it is the design of the benefits and how they administer mental health and substance use services, or Medicaid generally, that really do create incredible differences in the way they may have an opportunity to approach this work. I also want to make sure that I reference that Sherry Snyder is in the audience, who took my place, and of course is now facing all the budget cuts in Pennsylvania. And Jess Bradley is here as well, as really a special assistant who did an incredible job in interfacing with our Supreme Court Justice, who also did, as you did, Justice, made us all come to the table and play nice, and which has resulted in some great interface. So just a few brief comments about Pennsylvania generally, and then kind of get to the question. Pennsylvania is a county-based system, and I heard that there's a county rep here from the National Association. And county government in Pennsylvania plays a key role in all human services. They have legislative responsibility for mental health and substance use. They have responsibility in the children and youth system. They have responsibility for the county jail. So they have this broad berth of responsibility, and also they have relationships with schools and educational partners and et cetera, and the list goes on. And so when we contemplated a Medicaid program for mandatory Medicaid program in Pennsylvania, we naturally looked to county government to be really the engine behind that. So in Pennsylvania, county government was offered the opportunity to actually manage the Medicaid benefits. Of the 67 counties, over 40 counties actually assumed that responsibility, and so they have Medicaid as a tool in order to do human services and to really create solutions locally in order to do things differently. We also, in 23 counties of which the company I now work for, Community Care, has a direct state contract. One of the obligations that, on the state side when I was there, we required is that counties still have an active participation and role in that delivery model because of their because of their knowledge of their local systems. And even though they don't have the risk, they do have the responsibility and the partnership with us to move it forward. I was particularly gratified to hear Allegheny County reference. Not only are Allegheny Countyans very proud of the Steelers, but they are also, conversely, very proud of the recognition they had. And Allegheny County probably, it's a major urban center, and it has, in fact, created a human service and delivery system that touches everyone. And if you talk to anybody on the street in Allegheny County who needs a human services strategy for any reason, they know where to go. One of the pushbacks we often got from many, and certainly from many in the criminal justice system, is, who the heck do I call? You are a complicated, difficult system to manage. And we don't know how to interface effectively. We don't know how to create these continuity of care strategies. So we've been fortunate that because we have county government in charge and responsible for Medicaid, as well as all of the other funding streams that we have available to us, we've been able to maximize that revenue and be able to do things a bit differently. Again, one of the unique features of PA is that we are always in the top 5 of the amount of money we have generally in Medicaid and in non-Medicaid and in per capita. So we do have some opportunities that aren't available in other states, in the fact that Pennsylvania's had a very rich history of making a commitment to mental health and substance use services. And right now the budget is about $4 billion that is committed solely to behavioral health services. Even in our environment where it has been extraordinarily challenging, what Medicaid gave to the counties is the flexibility to say we need to be able to respond differently and uniquely based on what our county needs. So what is important in Philadelphia, what's important in Allegheny County, is not important in Tioga County, which is a very, very rural community in Pennsylvania. So we have allowed the flexibility in the program to say in Tioga County, where they had very little access, we have forensic peer services. We have Medicaid paying for peer services where a person who has a lived experience can then go reach out and treat and support someone who has that condition. On the criminal justice side, we can bill Medicaid until they go in the door for all those supports to help a person transition back out. We also have the issue, I want to comment on the state Medicaid letter about keeping folks enrolled. The practical reality is, from the state experience I had, is that Pennsylvania had no infrastructure to actually turn it off. And so the technical component became the obstacle, not the philosophy in doing it. So, as with many states, we did a workaround. We've done things like expedited enrollment, and so that the day a person, and we become knowledgeable that a person could be eligible because of their medical condition or their past eligibility, we will actually retrospectively. Now, Sherry said to me, don't say anything that's going to get us in trouble now that you're gone, because I'm here. We did, of course, with all CMS blessing and support, retrospectively engage folks so that Medicaid picks up the cost, so that the day the person is released, if they need a treatment strategy, Medicaid assumes that responsibility. Because I can't tell you the passion I feel about our obligation. When I hear about individuals going to jail to get treatment services, it takes my breath away. It is the obligation of the community system to respond. And so we have an obligation to respond, whether through Medicaid, through non-Medicaid resources, whatever that design is, we must respond and be a partner. There is not enough money in the universe to assume responsibility for everyone. And so the collaboration and the actual interface has been essential in Pennsylvania. In order for us to pick up the additional populations and even further strengthen, just briefly, I think states will need to do a couple of things. One is, I would argue, you do have to look at your existing infrastructure. What also gives us a little heartburn is don't blow up what might be working. So in Pennsylvania, we have a county-based system that has a lot of strength. We've been able to show increased access, cost savings, and an incredible commitment towards recovery and good outcomes overall to the program. So we want to build off of that to be able to even take a step further and assume the responsibility. We know the population that's coming in. We have them now. We have a state general assistance population. It is overwhelmingly drug and alcohol. But unfortunately, we do a medically needy category, so folks are often flipping in and out of service. This will give us a tremendous opportunity. We also know from Massachusetts' experience that the population even above that could potentially come in on the exchange, they also are often going to look more like our population of general assistance than they are individuals who are going to look like commercial. So states will want to look at your existing infrastructure and where you have your strengths and your collaboration. The other opportunity is in ERA, as I understand. There is an obligation when we set up the exchanges for each state to be able to determine where it is I belong. So am I eligible for Medicaid? Am I eligible for the exchange? Where do I belong? That is a wonderful opportunity to fix the glitch about coverage, so that you, in fact, want to advocate is as you're doing infrastructure and getting the infrastructure grants around eligibility generally, let's figure out states how to turn the switch off and back on so that a person remains covered, but they may not be able to bill while, in fact, they're in the door. I think the third thing is, and it goes back to much of the theme today, is the collaboration strategy. We really do recognize that it is our obligation, but we cannot do it alone. In all of the efforts that we have done in Pennsylvania that were absolutely led by a Supreme Court justice who said, you know, you all are going to come to the table no matter what, we really built on the intercept strategy so that every place along the continuum where we could make a difference, we decided we needed to make efforts to do that. But everybody had to put money on the table. The Department of Public Welfare put money on the table, criminal justice system put money on the table, local communities put money on the table. There was an investment in saying that this is all of our issue, not just one. It is a community issue. It is complicated, but it's absolutely a tremendous opportunity in ERA to design something that can, I think, really impact services overall. So. I could go on forever, but I won't.
Maybe the audience will give you another chance. We definitely look forward to the questions that I'm sure people have for you. But first, Dr. Clark, I was at a meeting yesterday with some policy people, and your colleague John O'Brien wasn't able to come, but there were academics and other federal folks, et cetera, who characterized the substance abuse portion of the expansion in ACA as being the biggest opportunity, the biggest happening, the place where there's the most to gain. And I know that you can speak to that, and in particular, how block grants are going to play in the post-2014 world.
Well, I want to thank you all for inviting SAMHSA to participate in this discussion. And as Larry Robinson pointed out, there are a number of people in the audience with whom SAMHSA has been working. And I'm here at the behest of Pam Hyde, the administrator of SAMHSA. But we've got partnerships with the Office of National Drug Control Policy, Department of Justice, National Institute of Drug Abuse, HRSA, and the Federally Qualified Community Health Centers, CMS, FDA, and a bunch of other government organizations. And we work very closely with state trade organizations like NASDAD, NASHBIT, and the county organizations. The important part about the block grant and the ACA is to remember that block grant funding is determined by the Congress. And so if the Congress decides that the block grant should go away, then there will not be a block grant. And of course, that hasn't happened. The key issue, as other speakers have pointed out, is having the community recognize the fact that that the ACA will not cover everybody who needs mental health and substance abuse services. That's a key construct. And then that benchmark plans may not include the breadth of clinical services necessary to foster recovery. Allison's paper points that out looking at substance abuse. Currently, only 49% of the state Medicaid agencies cover extensive outpatient care. 25% cover targeted case management, only 29% cover residential services, and 18% cover crisis care. So there's wide disparities in the existing portfolio of services that are available. So we need to keep that in mind. And we also need to keep in mind something that Nkuso pointed out, is that while there is savings, we need to recognize that there's a word that we haven't dealt with it, and that is stigma. When you're talking about people who are remitted to jail, there's the attitude that somehow they're less than deserving and less worthy. But as the previous speaker pointed out, we're going to pay regardless. And so part of this is indeed getting the Chief Justice of the state to say, well, wait a minute, public, that indeed this person may have a charge against them, but we're going to pay in terms of infectious diseases, we're going to pay in terms of public safety, we're going to pay in terms of public health. So saying that they're no longer eligible for services because we're going to save money off their backs is actually very short-sighted. We're going to spend money regardless. So we might as well have a comprehensive strategy that recognizes that public health is an integral part of public safety. And that even though this person may have offended, since, of course, we've talked about pre-trial and pre-decisions, and we don't know that, in fact, they have offended, we know they were arrested. So that even though that person may have offended, we need to deal with the health care issues. So that gets us back to the block grant. As the ACA will address a large number of individuals who previously did not have access to health care, the block grant can then become a complement to that that to foster recovery support services. And we are working with the state authorities to look at what is the future of the block grant and from the perspective of if the ACA kicks in 2014 with alacrity and dispatch, how are we going to deal with these other issues? And so we are, in fact, working very closely to address that. We want to make sure that the behavioral health infrastructure survives this transition. Allison's paper and Maureen McDonald's paper pointed out you may not have the infrastructure capacity to deal with some of these issues. So, in fact, the block grant can help foster that. And we need to foster the issue of housing and homelessness came up, the issue of employment. There's also the issue of literacy. There are a host of recovery themes that need to be addressed if we're going to return people to the larger society so that, in fact, we can deal with their issues. And the block grant could play a critical role in fostering that. So it would work in partnership with Medicaid and the health exchanges in order to facilitate recovery and also to promote destigmatization of individuals associated with the criminal justice system. And again, because you have been arrested, it doesn't mean that you're guilty of anything. It simply means that you've been arrested. And we need to keep that in mind. And then, of course, a host of other issues that we're working with in terms of reentry, those people who are in fact convicted, and it turns out that their crimes are more associated with their substance use or their psychological issues, that it does us a better service to reintegrate that individual back in the community in a comprehensive way, and where recovery support services can help facilitate that. So we see the block grant as addressing a host of issues. Currently, 39% of the people served by state mental health authorities are uninsured. 61% served by the single state authorities are uninsured. So our hope is that Medicaid will play a major role in 2014, and that the block grant will be a complement to that by addressing these other issues. And then we will continue our partnership with the criminal justice system and dealing with reentry areas and dealing with the broad public health component so that we can address this. And I really appreciate the judge's comment, because from the substance abuse perspective, over 30% of the individuals referred to substance abuse treatment come from the criminal justice system. So destigmatization, getting the society to recognize that these are our sons and daughters, fathers and mothers and cousins and brothers and sisters, that we need to make sure that you can't just walk away from them because you say, well, they've offended, they've sinned, and we don't owe them anything. You've got to pay one way or another, and Washington State data makes it clear that better that you deal with this in a comprehensive way so that you don't pay in the long run.
So thank you, Dr.